Great. Welcome to our February Fast Facts on One Health, what is it, and what does it mean for every clinician? This is the CME accreditation statement for your review. And with the obligatory financial disclosures, there are none for any of the presenters today. Learning objectives include, upon completion of the webinar, participants will have an increased awareness of the core principles of One Health and discuss the challenges and future perspectives of One Health, enhance knowledge of the current H5N1 avian flu pandemic in the context of public health responses and clinician roles, and improve knowledge of clinician roles in diagnosis and treatment of H5N1. I'm Hillary Spencer, and I'm facilitating this. And the presentation will be presented by Dr. Matthew Leslie, who is one of our IDPH laboratory data and zoonotic disease epidemiologists, as well as Dr. William Sander, who is an assistant professor of preventive medicine and public health at the University of Illinois, Chicago College of Veterinary Medicine. And I will hand it off to you, Dr. Leslie and Dr. Sander.
Wonderful. Thank you, Dr. Spencer. I'll take over and share my slides. All right, I think we should be ready to kick off here. Thank you so much for joining us. I'm really excited to speak to you today about One Health, what it is, and what it means for every Illinois clinician. What we'll cover today is a background on the One Health approach to public health, examples of One Health in action in Illinois. Specifically, we'll talk about rabies potential human exposures, because those are a very common everyday facet of life in Illinois, and some One Health concerns in Illinois production and companion animal medicine. And then finally, we'll drill down deeply on H5N1 influenza, which really is the One Health challenge of our time. The One Health framework for public health states an acknowledgement that we're all interconnected, and the things we do and the choices we make impact everything and everyone around us. Here in the graphic, we see the intersection of environment, society, and healthcare sectors and how they're all intertwined. Although the intersection of wildlife and agriculture and society is a little smoother and less stark in Illinois than it is in some places, these interactions are doubtless occurring all around us all of the time. The One Health framework for disease reminds us that a simple germ carried by a cow or pig, mosquito or tick, can alter our lives tremendously. And indeed, we all saw this firsthand during the COVID-19 pandemic. Further, we must acknowledge that these interactions in no way are diminishing in modern life, and that the march of climate change, globalization, urbanization are bringing these things closer to the forefront of our everyday life all the time. We're going to begin here with a live poll. We will hopefully see a poll launch that we can respond to if we'd like, but if not, we'll just take a moment here to reflect. What % of current diseases and what % of emerging diseases are transmissible between humans and animals? Please take a moment to log a response if you would like. We're getting a few responses, so I think the poll is working.
The poll closed a little bit early, but
okay, that's okay. No worries. Attendance or CME is not based on this. Just a fun exercise. And the answer is D. A large portion, the majority of current disease that is understood in human beings can be transmitted to and from animals. And 75% of emerging diseases are zoonotic in nature. Here we see the Illinois Stop and Report Infectious Disease poster with highlighted sections. I've pulled out everything from the poster that is reportable in Illinois that may undergo zoonotic transmission in some circumstances, and bolded our names of classic zoonotic diseases. Almost every reportable disease in Illinois could undergo zoonotic transmission under the right circumstances. And the ecology of these diseases in our state are impacted not just by human factors, but by changes in agricultural practices, industrial practices, as well as animal and vector ecology. One health practice is more than acknowledging the interconnectedness of living things, but rather understanding where those interconnections present themselves in everyday life and wellness of our patients. For the MDs who have joined us, I'll ask you to consider how often you are inquiring about the health of the family pet. Perhaps you'll learn that patients are helping to manage a resistant staph organism on a daily basis. Further, I wonder how often you discuss safe animal husbandry practices with your patients in childbearing years. For the veterinarians among us, I wonder how often we inquire if our patients are living with an owner that is pregnant or immunosuppressed, and how often we're discussing the owner's indoor smoking habits in our respiratory health cases. A number of studies have reported that up to a quarter of pet owners say that they would cease their smoking behaviors if they learned that it was harming the family pet. For both DVMs and MDs, I wonder if you consider inquiring about whether the owner or the pet has recently had a tick as a proxy for the other's relative tick-borne disease risk. We know we love to hike with our pets, and so if our pet has sustained a tick in wildlife, it seems possible that we have as well. Similarly, if we had a tick bite in our backyard while gardening, that is a good proxy of disease risk in our pets in our backyards. A central tenet of One Health communication is a bidirectional and open communication between healthcare practitioners. This includes doctors, nurses, pharmacists, veterinarians, animal control officers, wildlife biologists, public health practitioners. To the MDs in the room, I wonder, do you have a community vet you could call with a question on parasitic or dermatologic disease? To our veterinarians, have you formed a relationship with a local pharmacist to ensure you're staying abreast of local pharmacy law changes? Pharmacists, are you comfortable with the wide-ranging dosing differences between human and veterinary patients and the differences in indications for certain medications? I would encourage us all to try to form relationships within our community with other healthcare professionals. You'll be surprised how often these can come in handy. Recently, here at the state of Illinois, we had a situation where a bat was found on the floor of a assisted living facility. That's an odd place for a bat to be found in the midday. And so we spoke with wildlife biologists from the USDA to discuss bat behaviors this time of year and how long that bat probably could have been in the building or in that space without being noticed to help us gauge the relative risk for exposure to the residents living there. We'll now move on to discuss examples of One Health in action in Illinois. I'll present a scenario to our ER doctors in the room. You're contacted by a patient who was returning home from a weekend trip, putting away some fishing gear in their garage. They felt something hairy brush against their hand in the dark and saw something fly out the window. Is this a scenario for rabies exposure prophylaxis? We're going to dive really deeply into rabies for a few minutes because it's often a One Health headliner and it's an everyday occurrence throughout the state of Illinois. We'll have another live poll now. David, if you could help launch it. What percent of bats tested in Illinois are rabies virus positive? Seeing some good responses here. We'll leave it up for a little bit longer. Thank you for all who are participating. All right, I think we can close it down. The answers show that we are aware that rabies virus is in the state of Illinois. The correct answer is D, 3 to 7%, depending on the year, which is on one hand a lower number, but in the hands of a clinician and practitioner is very high when we consider how many bat exposures occur in Illinois patients every year. The fact that 3 to 7 of those percent of those are rabid is rather concerning. Rabies post-exposure prophylaxis consists of a different protocol for persons who have and have not been vaccinated previously for rabies. For persons not previously vaccinated for rabies, the protocol includes the administration of rabies immunoglobulin infiltrated into the site of the wound, followed by 4 rabies vaccine doses on day 0, 3, 7, and 14. For people who have had pre-exposure, a full set of pre-exposure vaccines, PEP includes 2 rabies doses on day 0 and day 3. Post-exposure prophylaxis related to our scenario is recommended for the following bat exposures unless the bat can be tested negative for rabies. So a known bat bite, physical contact with a bat where a bite can't be ruled out, like fiddling around in a dark garage, waking up to a bat in the room that you're sleeping in, or a person alone in the room with a bat who isn't capable of saying whether or not they were exposed, either because they were sleeping, intoxicated, are too young or old to communicate that, or have a developmental delay where they cannot communicate their risk. Bat exposures are a bit different than other exposures to wildlife in the state because they're so small and elusive and often get into our homes. With most of our high-risk species, we're worried more about bites from the animal, but we have these scenarios for bats that indicate the need for post-exposure prophylaxis. A quick rabies primer. Rabies derives from the Sanskrit word rabas, which means to do violence. It is an acute progressive encephalomyelitis to which all mammalian species are susceptible. The incubation period for rabies is prolonged and variable and depends on the exposure site and the dose of viral inoculum. Highly innervated tissues, such as the hands and the face, are associated with shorter incubation periods. The rabies virus must first travel to the brain before it can cause symptoms and before it enters the salivary glands. This is the reasoning behind observation periods in companion animals. The thought being that if the animal was rabid at the time of the bite, if rabies virus was in the saliva at that time, it should have already been in the brain causing neurologic illness. And so if the animal, a dog or a cat, survives the 10-day observation period without any sign of neurologic illness, we can feel comfortable that rabies virus was not present in the salivary glands at the time of the bite. Over 4,000 US animals each year test positive for rabies, and over 90% of this is in wildlife. Transmission of rabies almost always occurs when following a bite, when virus-laden saliva enters tissues. More theoretically is that saliva from a rabid animal could enter breaks in the skin or open mucous membranes, and there have been rare laboratory exposures to rabies virus. The theoretic scenario of saliva entering broken skin is one that comes up a lot because that could theoretically occur a lot. For instance, we get calls from people who are, let's say, feeding alley cats and put out a bowl of food. Will frequently wash that bowl and come to see that a raccoon has been eating out of that bowl, and they worry about cuts on their hands having washed that bowl. Or another story recently of a gardener who was had a wound on their hand from working with some rose bushes, went to grab a tomato off the vine and had seen the tomato had been eaten by a wild animal. While those do represent scenarios where theoretically there's saliva entering a wound, we know that rabies virus is not very stable environmentally, and so we do not categorize those as potential rabies exposures. Really, it would need to be a direct exposure of wet saliva into an open wound, which is a pretty rare scenario. Rabies post-exposure prophylaxis is very costly and it can be often overutilized. It needs to be recommended when needed, but not for every exposure. We frequently talk to people who tell us of $20,000 bills from a complete course of rabies post-exposure prophylaxis. And for most Illinois families, that would be a devastating bill if they were uninsured or underinsured. So there are millions of bites and thousands of emergency department visits every year. But what do these patients most often need? Prompt wound care, antibiotic therapies, tetanus boosters, and a full rabies risk assessment. Don't always rush to administer rabies prophylaxis. Rabies post-exposure prophylaxis is a urgent medical scenario, but not an emergent medical scenario. We have some time to loop in public health practitioners to do full rabies risk assessment and ensure that we are giving post-exposure prophylaxis when needed. Lastly, I would urge health providers and health systems to consider how follow-up doses of rabies vaccine after an exposure can be administered outside of an ER setting, either at a community urgent healthcare center or an infusion center or a primary care office, somewhere that can help lessen the bills associated with this and keep our wonderful ER clinicians focusing on more emergent issues. The relationship between humans and animals, both pets and livestock, allow for the transmission of infectious diseases. An increasing number of people are living with companion animals, and healthcare professionals and pet owners need to be aware of pertinent zoonotic agents and the human populations that are at risk for those infections. We know that US pet ownership has been increasing for the past 40 years, hitting a peak during COVID, and now numbers are coming down a small bit. But for the most part, Americans are owning pets more than they ever have before, with over 45% of US households reporting dog ownership and over 32% of US households owning a cat, with most households who own one pet owning more than one pet. Animals harbor a number of concerning zoonotic agents that can be found consistently in developed countries with high standards for veterinary and human health care. And so we need to be aware of the zoonotic disease concerns in the small animal veterinary clinic. These can range from GI parasites to GI microbes like Campylobacter and Toxoplasma, to skin concerns such as ringworm and resistant bacterial infections, to rarer and more concerning infectious diseases such as Brucella and leptospirosis. I know in the small animal clinic, I always consider leptospirosis a short moment after I wish I had considered for leptospirosis. And so it's very important to always, be cognizant of wearing gloves and not eating in the small animal workspace. There are zoonotic disease concerns, of course, with large animal medicine as well. Some of these infections may include threat agents such as anthrax, brucellosis, and Q fever, but can also include skin conditions like ringworm, foodborne pathogens such as E. coli, and cryptosporidiosis, and very concerning infections like tuberculosis. A reminder that these doctors, technicians, owners, and producers in the state of Illinois are our fathers and mothers and sisters and friends and community members. They are our patients, and we need to be aware of the infectious agents they're exposed to. We'll now transition to talk about H5N1, which truly is the one health challenge of our time. The global pandemic of H5N1 avian influenza over the past couple of years has presented itself as the one health challenge of our time. Every day working with the state of Illinois, it feels like I'm reading from a One Health textbook with examples of wildlife interacting and spreading disease to our agricultural systems, of agricultural infections spreading to human patients, calls from the members of the public concerned about wild bird die-offs and how that interacts with our community members and pets in our home. And so to tackle this pandemic will truly require a One Health approach from medical professionals of all walks of life. Today, we'll cover the emergence and current status of H5N1 in the United States, and we'll provide Illinois clinicians with tips for how to handle potential cases. We'll quickly cover the emergence of H5N1 from 1996 until today. It was first identified as highly pathogenic avian influenza in southern China when it was identified in a goose in the Guangdong region in 1996. In the late 90s, poultry outbreaks started occurring in China with over 860 human infections and a very high mortality rate. In 2003, after some quiet years, H5N1 reemerged to cause more widespread poultry outbreaks across Asia. In 2005, wild birds spread H5N1 to poultry in Africa, the Middle East, and Europe. And very notably in 2021, a new H5N1 virus belonging to clade 2.3.4.4b with a wild bird adapted N1 neuraminidase gene emerged and quickly predominated worldwide. By February 22, the virus began causing poultry outbreaks in the US with rare sporadic human infections. And from Feb 22 till now, the H5N1 virus has been detected widely in US birds and other mammals. In March of 2024, the Texas Department of State Health and Human Services reported the first detection of H5N1 in dairy cattle. Again, that was clade 2.3.4b and genotype B3.13. In a moment, we're going to have a look at the annoying influenza nomenclature. As of February 19th, 2025, H5N1 had been detected in over 1,500 flocks in all 50 states. It had led to the astounding depopulation of over 162 million head of production poultry livestock, had been detected in over 972 dairy herds in 17 states, and had resulted in 69 human infections. 23 of these human infections are associated with working with infected poultry, 41 of which are associated with work with infected dairy cattle. 2 cases are classified as other, and 3 as unknown. Unfortunately, there has been 1 US influenza H5N1 fatality. Of the 69 known human cases, 64 of which were found via targeted surveillance of people known to have had exposures to sick animals. 5 of which, however, were identified via national flu surveillance, which is more concerning because it suggests the possibility of community spread of H5N1. There's been no definitive mention of that yet, but randomly finding an H5N1 positive person with no known animal exposures is concerning. To date, no dairy cattle or human patients have ever tested positive for H5N1 in the state of Illinois. Influenza nomenclature is arduous, but I think it sometimes gets in the way of us understanding the headlines. And so I'd like to quickly cover it. Avian influenzas are classified as either low pathogenic or highly pathogenic based on the severity of disease they cause in farmed poultry. So highly pathogenic avian flu is highly pathogenic in farmed poultry. Furthermore, influenza A viruses are subcategorized based on their hemagglutinin or H and neuraminidase or N genes. So influenza A H5N1 is a influenza A with hemagglutinin 5 and neuraminidase 1. They can be further classified into genetic clades based on the evolutionary relationships of their H genes, and there can be multiple genotypes within a clade. Currently in the headlines, you're seeing discussion of the genotype D1.1, which is associated with wild birds, and B3.13, which is associated with dairy cattle in the US. Notably is that the D1.1 has produced more severe infections once in Canada and once in the United States. The formal naming convention of any influenza virus is the virus type / host origin / geographic origin / strain number / year of isolation. So in a scientific publication, that's how it's presented. H5N1 has been widely detected in wild birds, farmed poultry, farmed dairy, wild mammals, and humans, unfortunately, throughout the United States. In the top right-hand corner, we see a map of all sorts of mammals that have, wild mammals that have contracted H5N1. And we see the USDA shows the flyway of migratory birds associated with those infections, a true One Health scenario. Transmission of H5N1 is thought to be similar to seasonal influenza, which occurs primarily through breathing air with infected virus in it. Transmission may also occur by direct or indirect contact with milk, oral secretions, blood, organs, or fecal material from infected animals. And notably, very high titers of H5N1 are found in milk due to a unique tissue tropism, or where a virus likes to live, for H5N1 in mammary glands. We see a couple examples here of how H5N1 could spread in the dairy or poultry industry. H5N1 has shown different pathogenicity across species in the United States. It has been and remains to be highly pathogenic in farmed poultry. It has mixed pathogenicity on different types of wild birds. It has been highly pathogenic in dairy farm cats. Perhaps this is due to high milk titer exposures on the farm, and has been mild to moderately pathogenic in dairy cows, with signs of illness being reported in less than 10% of cows in infected herds, and most animals recovering with supportive treatment with low rates of culling and mortality. This underlies the differences in farm management between dairy and poultry. On poultry farms, because all of the poultry are likely to succumb to the disease right away, the USDA undergoes depopulations to reduce the amount of virus in our society and community and environment. While on dairy cow farms, because the cows tend to be less sick and more manageable, we isolate that farm and look to support the animals through those infections while supporting people and ensuring there's no spread. So far in the United States, H5N1 has been mildly pathogenic in US human patients who most often show mild respiratory symptoms and conjunctivitis. How this differs from what has previously been observed in Southeast Asia is a matter of active debate. And there are hypotheses about the relative health of agricultural workers in resource poor agricultural settings versus research rich agricultural settings, but really is a matter of debate. The clinical course of H5N1 is similar to regular influenza, with fever, cough, muscle aches, malaise, headache, and sore throat, as well as abdominal pain, vomiting, and diarrhea, which can be observed. Notably with H5N1 infection, there can be clinical signs of conjunctivitis. Eye discomfort and redness is common. It can occur alone, but most often accompanies other symptoms. And similar to other influenzas, it can progress to lower respiratory tract disease 5 to 7 days after symptom onset, with signs of difficulty breathing, shortness of breath, chest pain, and tachypnea. Those who've been admitted to the hospital often show hypoxia, signs of pneumonia, laboratory blood work changes, and radiographic changes such as patchy interstitial lobar or diffuse infiltrates and opacities. Less common clinical complications of H5N1, similar to other influenzas, include pneumonia, acute kidney injury, sepsis, shock, DIC, and multi-organ failure. The pandemic potential of H5N1 is a omnipresent concern. A recent publication in the journal Science outlines that a single amino acid mutation at residue 226 of the hemagglutinin gene would be sufficient to enact the change from avian to human specificity of the virus. So this is a concern for public health professionals. That being said, the CDC's current risk assessment for H5N1 in the United States is low because the majority of public health has little risk of H5N1 because the majority of the public has little exposure to sick animals. People with unprotected exposures to sick animals, people working in the poultry and dairy industry, people working with or encountering sick wild birds are at a greater risk. And Illinois clinicians need to be cognizant of that risk and who in society has greater H5N1 risk. The IDPH has been doing a number of things to prepare and plan for H5N1. We've been generating and releasing education materials for ag workers on workplace hazards and PPE, participating in national awareness and planning calls, maintaining close relationships with our other state of Illinois partners, like the Department of Ag and DNR. And we all performed a tabletop exercise to plan for H5N1. We've been monitoring for potential human cases with our surveillance platforms, Sentinel surveillance sites, syndromic surveillance, and wastewater surveillance. And we've been assisting with the few poultry outbreaks by monitoring any individuals who had contact with positive or presumed positive animals for 10 days after their exposure. We've coordinated the release of PPE and pre-positioning to Illinois farms with the Illinois Farm Bureau. And our laboratories have been helping to subtype all ICU patients within the state of Illinois who have influenza as part of the government's call for further surveillance. And this week, or rather next week, we are instituting the Illinois portion of the National Milk Silo Testing Plan to help surveil for H5N1 in dairy products. The next two slides are a lot, but I wanted you to have the information for our Illinois clinicians. What to do if you suspect H5N1? Consider your patient's unique exposures. There shouldn't be suspicion in the majority of our patients. If H5N1 is suspected, please immediately notify state and public health officials for testing, monitoring, and follow-up. Isolate the patients and follow recommended infection prevention and control measures. Please be using recommended PPE. The CDC advises to start empiric antiviral therapy if there is suspicion for H5N1 while awaiting results. Patients with mild illness can isolate at home and receive supportive care, but patients requiring hospitalization, we should please work with state and local health authorities to arrange for the best avenue of care. If H5N1 virus is confirmed, clinically stable patients would home isolate until they are clinically improved for at least 7 days have passed since the onset of their symptoms. And we would look to start post-exposure antiviral prophylaxis for household and other close contacts. And we would ask those contacts to monitor for any signs of illness for 10 days after their last exposure to the known case. Again, I reiterate the importance of speaking to local public health to help arrange testing, monitoring, and antiviral prophylaxis. Here are some information I want you to have on the requirements for H5N1 testing. H5N1 testing samples differ by where the patient is showing clinical symptoms, whether or not those are acute respiratory symptoms or conjunctivitis or lower respiratory tract disease. All of this information is available online, but generally we're collecting a nasopharyngeal swab and a nasal and throat swab and combining those two swabs into a single tube of viral transport media. We want to collect multiple respiratory specimens from different sites on multiple days to increase our likelihood of diagnosis. And we want to be wearing full PPE, including an IOSH approved N95 respirator, eye protection, gown, and gloves when collecting those samples. Lastly, I'll mention that the Illinois wastewater system is helping to surveil for influenza spread in Illinois wastewater. This summer, we undertook a project to follow up on sites that were flagging with high influenza A levels in our wastewater. We had numerous meetings with local health departments to understand local risk and surveil and increase local surveillance. We had a lot of good outreach and education discussions. We're able to ensure no H5N1 transmission in the state, but never identified a surefire cause of increased influenza levels seen over the summer. Lastly, I'll leave you with the thought of the future of zoonotic disease. Zoonotic diseases are likely to expand beyond their historic ranges due to climate change, urbanization, globalization, and the widespread migration of human and animals. And we as Illinois clinicians need to be thinking about how we will continue to meet this challenge. Thank you so much. I'll now pass the mic to Dr. Will Sander.
Great. Thanks, Dr. Leslie. Let me bring up my slides here as well. So Dr. Leslie did a great job of providing an overview about One Health at a high level, and then delving into some of the efforts that are going on here in the state, particularly from the Illinois Department of Public Health side. I wanted to provide a quick update on some of the larger efforts we're trying to do around coalescing One Health within the state. And part of that was driven by this workshop that we hosted here in Champaign back in December of 2024. And so I'm an assistant professor here at University of Illinois Urbana-Champaign, but also have an affiliate appointment at University of Illinois Chicago. And so one of the big drivers here we wanted to think about was how do we try and move some of the One Health discussions forward. And so this has been an ongoing spot for discussion for over a decade. And we've had One Health workshops happen in University of Illinois since the late 2000s. But obviously it's been driven more, especially from COVID, and now you hear this great example, or unfortunate example, of H5N1. And so we brought together key stakeholders from across the state in early December to have some landscape kind of an assessment of what's going on in the One Health space. What can we prioritize as a state to move these initiatives forward and try and break down some of the silos that are in place? And so you can see up here on this slide the key goals we had around fostering collaborations. We hadn't had a One Health workshop in over 6 or 7 years. And so this is a great spot for us to reinvigorate some of those discussions. And then understand what areas we might benefit from as a state in looking at this, not just around infectious and zoonotic diseases, which is certainly one area we discussed, but around other areas as well. And then how can we prioritize those One Health goals moving forward? So these are the key focus areas we decided to pull on for this 2-day workshop. And so you can see zoonotic disease was obviously one of those, but we also had some other very broad categories around agriculture, and not just animal agriculture, but agricultural in general. Environment, a very broad topic. Climate change, access to healthcare, because that in and of itself is a very One Health driven issue, from the built environment to access for our veterinary patients as well as our human patients. Antimicrobial resistance, and then data interoperability, because as you can see from like wastewater surveillance, data and surveillance is really important, and how do we try and make sure that that can be shared across the different sectors. And so the overall structure was, we were thankful to have Dr. Vora come in and kick things off for the Illinois Department of Public Health. And then we had these quick lightning talks around each of these 7 areas. And then we actually brought in the state public health vet from the state of Washington, Dr. Beth Lipton, to talk about what the state of Washington had done back in 2023, which is very similar to this workshop that we hosted in December. And then we actually broke apart into small groups around each of these 7 areas and really had a chance to dive deeper into what we could do to within those spaces. What are the barriers and gaps we have? What strengths and best practices do we have in place already in those 7 areas? And what are some potential solutions and approach there? And so over this discussion, and this is one of the breakout groups here happening, thinking about climate change, actually, we were able to, each group presented 5 to 7 solutions or areas we could focus on within the state of Illinois that we thought would fit well, that were important, and that might be beneficial in the next 3 to 5 years. Now, obviously, if you take 5 to 7 solutions from 7 different groups, that's a lot of areas to try and focus on. So we wanted to think about how can we prioritize what to do from there. Before I talk about that, I wanted to mention these are some of the organizations that were represented. We had over 60 attendees, and we had folks from the government side of space, from Illinois Department of Public Health, Illinois Department of Ag, Department of Transportation. We also had Illinois Farm Bureau there as well. And then we had folks from the local public health departments, including Champaign-Urbana Public Health District and Chicago Department of Public Health. And we had some of the laboratories, some of the big laboratories, including Argonne was there. And we had some representatives from Pacific Northwest National Laboratory. We had Lincoln Park Zoo represented. And then federal agencies from FEMA to Department of Justice with FBI and USDA. And then finally, we had the university systems, particularly University of Illinois systems, but also Northwestern represented too. So it was a great congregation of folks across a wide variety of areas. We obviously had good representation from the veterinary space as well as the physician space and laboratorians. Environmental representation was smaller, but still significant. And so after we got these lists of solutions from each of our breakout groups, we basically put those up on various very highly technical situation here, put those up onto the wall and had people go around and rank them based on how much time this would take to do these solutions and how much resources, whether personnel, financial, or other types of resources it would take, and put little dots on these white papers here. And then we went through, and by we, I mean my clever Dr. Slogman Chakraborty, and tried to map out. So this is an example here of what we're talking about from climate change. This is one of the groups, and they had 5 different solutions proposed. And so people put up the numbers, solution 1, solution 3, solution 4. And we basically crowdsourced what they thought it would take for resources on the x-axis and time on the y-axis, and then average those out. As you can see, kind of an example matrix here. And so obviously this is not completely objective, quite subjective in fact, but we tried to create an objective process to it to think about how we could prioritize this, because One Health is such a broad topic and there are so many different avenues to go through in pursuing this. So once we went through those, we came up with the list of solutions or action items, and then we mapped out the top 5 that required the most time and resources, but arguably might have the biggest impact, and those that required less time or resources. So I just wanted to present those briefly here to you now to think about where these might fit and how you might fit into these spaces too. So one is obviously building surge capacity, which I think is something that everybody would love to have. And that surge capacity can take a lot of different avenues. One example was thinking about how can we use universities as a backstop for housing some of the equipment that might be needed, or some of the personnel that could be mobilized and pulled into application when surge is needed. Advancing monitoring and sensor technologies. You heard about wastewater surveillance. How could we better utilize that to pull data like that, as well as air sensors and other technologies to then make more robust models and prediction aspects? How can we invest more in public health workers? So that could be at a state level, it doesn't have to be at the federal level. So you can provide more timely access to needed care, having more inclusive, accessible, safe, and comfortable care, and a usual source of care, right? So not everybody has that. In fact, that's oftentimes can be a luxury for some folks. And then legislative action, obviously, to establish a cabinet level multi-agency work group to develop a One Health framework. So this has happened in New Jersey. That's what these House and Senate, or this is what happened at the federal level. That's what this House and Senate bill happened back in late 2023. And so that's what pushed CDC as a lead agency to develop the One Health framework, which was released last month. And I'll talk more about that in a second at our state level. And then more effectively transitioning research into practice via education, communication, advocacy, and knowledge. So obviously, these are some big buckets. And so an example on this last bullet might be climate-related issues that we could pull in from research and translate that into better preventive measures. Or how can we move that into an ER facility so that we can anticipate, with heat-related climate events, such as, our heat spells getting longer in July, anticipating what sort of cases will come through the ED in that scenario. And then those with least time or resources, having a speaker bank of around One Health that producers could tap into, community partners could tap into, et cetera, within the state of Illinois. Building and maintaining institutional trust. I think this is a big one that we come back to because communication is so critical and we all are all strapped for time. How can we make sure we have those sorts of relationships in place? Defining priority problems, which is what part of this workshop was doing, right? Set up a registry of data owners. So getting to that data interoperability piece, who has what types of data and how can those be shared? How do we know who has that and how can we request that information? Most people are very willing to share that data, particularly if it's de-identified and doesn't have personal health information. How can we better share that information? An executive order to mandate that One Health principles be considered in all administrative rulemaking. This is thinking about pushing at the federal level, but could also be talked about at the state level. And there is an effort right now from led by IDPH around One Health Illinois. So the next steps are really developing a white paper, as we often do after a workshop, thinking about some of these action items and what we could do and have that re-released for public consumption in the next 3 months. Continuing effort on a formalized state level One Health framework. And so this is actually moving forward already. So there have been bills introduced in the last 2 weeks on both the Senate and the House side within the state of Illinois. So Senate Bill 291 and House Bill, which is a companion bill, 1863, were both introduced. And so those are going through active testimony right now, witness slips, things like that, to basically develop a One Health framework. And so these bills would ask for a task force representative across the 3 sectors, human, animal, and environment, come together over the next year and a half to develop a framework for the state of Illinois to push One Health forward. And then you continue to work on partnerships at the local level. You heard some great examples from Dr. Leslie in his slides about, just thinking about even what do you ask your patients when they come in about animal exposures within their house, within their workspace? What sort of other places can we think about how to integrate this and talk with our local public health departments? So obviously happy to take questions after Hillary jumps on, and so I'll stop sharing my screen here and pass this over.
Thank you both, Dr. Leslie and Dr. Sander, for the great presentations. Very timely to be talking about One Health, obviously with H5N1, but there are so many threats, which I think you've highlighted, and really appreciate this conversation. I think there are a lot of questions. Just looking through, I think most of them have been answered. Are there any that you all would like to highlight, or if anybody has a question that they would like to ask verbally, please raise your hand. We can take you off mute, but I know we've been answering a lot of them in the chat. Dr. Leslie, are there any that you want to sort of highlight the answers to as well?
I think nothing on my end. Dr. Spencer answered a very good question on airborne precautions. That was wonderful. Someone asked about a veterinary health professional checking their dose of rabies titer. They're titer in their blood. I think that's a very good idea. When I have had it done at my private Doctor, it's been covered by my insurance. I can't speak to everyone, but I think that's a good idea for veterinary professionals. I think we should also be considering about more pre-exposure vaccination for other facets of the veterinary industry. Often it's just the veterinarian in a veterinary clinic who has been pre-exposure vaccinated. I think we need to consider others who are at risk, animal control officers, veterinary technicians, other professionals in Illinois. And it is recommended for very avid travelers. I've been bugging my wife Libby to get vaccinated because we have some trips coming up. So please, of course, review those pros and cons with your doctor. But we're very thankful to have a very safe and effective vaccine. And we don't often think about this, but rabies is a vaccine preventable disease.
Thank
Are
you.
there
I
any
think there
other
was,
questions?
oh yeah. I was going to say, well, while people are thinking about their questions, there was also a question about, that was answered in the chat about, whether they're looking back to see how it was risk in lower risk situations. Is it sometimes safe to hold off on initiating rabies PEP for the full 10 days? A companion animal is under rabies observation, and that was answered. But I think it'd be worth speaking to that verbally and just reminding. It's a good opportunity to remind folks that the local health department and the state health department are here to help with those decisions. I think you highlighted that the decision is an urgent but not emergent one. There is time to make that decision. I wonder if you want to speak to that a little bit too.
Sure, and I'll if needed, Dr. Austin, our state public health veterinarian, will speak up. But yes, it is urgent, not emergent. We always have time to take a beat, contact our local health department, contact Dr. Austin or myself here at the Illinois Department of Public Health. It is okay to not administer, not only is it okay, what we should be doing is if a dog or cat can be observed, and they were not acting in a manner that is outwardly suspicious for rabies at the time of the bite, which is by and away the most common scenario, that we should not administer prophylaxis. We should carry out the rabies observation. If the animal should succumb to neurologic disease or present with neurologic disease during that observation, then most likely we would test the animal, and still then we would wait for the test result. So yes, let's carry out rabies observations when we can. It is absolutely acceptable and recommended to hold off on post-exposure prophylaxis when we have an animal who can be observed. Now, animals who can undergo observation of that nature are dogs and cats, and there are observation periods for agricultural livestock. That is 30 days. It's extended out further. But these observation periods do not extend to wild animals or exotic animals, reptiles, lizards. Well, that wouldn't be the case, but do not extend to other types of mammals in the state of Illinois. Only, for the most part, dogs and cats, and rarely agricultural species. When possible, let's always try to test the animal. So if we have a raccoon or skunk or bat, if it can be safely collected, please do so, and please hold it for testing. The state of Illinois laboratories at Carbondale, Springfield, and Chicago can assist with very rapid testing. And again, almost all of the time, return an answer in a timely fashion such that our providers can wait on making pre-exposure, post-exposure prophylaxis decisions. So if possible, test. If possible, observe. Please always reach out to a local health department to discuss. And if needed, you'll find Dr. Austin extremely reachable and extremely responsive if you have any questions.
Thank you. I think that's a really great point. And I know you brought up the recent situation in a long-term care facility, and there was some interest and questions around that as well. And I think testing highlights how it would have been, there would have been a lot of factors about that would have made it a whole lot easier. We see those in other settings too, so I think extending the message there was I think some chatter about this too, both not releasing and also like how you're handling wild animals. We've seen that, people are very excited about engaging with the natural environment in schools and what have you, and want to show and share. And we've been working on that message with regard to bats. And I think this is an opportunity with other birds and wildfowl that we're seeing too, that we really need to be careful and have the appropriate training and the appropriate folks involved in doing that. But certainly being able to test the animals for rabies in particular is really helpful in those multiple exposure situations too, for the individual, but as we think about larger situations. So we appreciate the community's ability to help extend that message as well.
Absolutely, yes.
I'm not used to doing this, so I don't think I see any hands, but we'll give one more opportunity for any questions from the audience. We have a couple more minutes. I don't think there are any showing up there. Anything else that you all, that Dr. Sander or Dr. Leslie, any messages you want to give before we wrap up?
My last one would be about wild birds at this time. We really need to be, unfortunately, letting them alone. We unless we're a highly trained veterinary professional wearing extensive PPE, we should not be handling them. We should not be transporting them. There is a rather high risk of H5N1 with wild birds in our state right now undergoing migration. And although we do want to help all the species and all the living things in our state, we need to do so in a manner that protects human health. And so please contact your local wildlife biologists, the state of Illinois DNR, a local wildlife rehabber, but please do not be interacting with wild birds in an untrained, less than professional manner.
Thank you.
Yeah, I'll echo that, as my clinical appointment here is in the Wildlife Medical Clinic, which sees about 2,000 patients a year. And we have very strict protocols in place right now because of H5N1. And although I don't want to stigmatize bats or birds, because it's really important to have these natural species and our engagement in the biodiversity of the state of Illinois, there are certain concerns right now that are definitely real. And so we do need to be cautious.
Thank you for that. It looks like there's one question that popped into the point on wild birds. What about birdhouses in the vicinity of home pets? Should birdhouses be moved? Is there any guidance around that at this point?
So I've not seen a scientific publication that I can point to that presents a risk ratio that can back up this guidance. But my personal guidance, the thing I've been telling my friends and family, would be to take down bird feeders at this time. There's a risk reward to everything. I want to see pretty birds. I want to feed pretty birds. But especially with our outdoor house cats that may be interacting with those feeders, bringing those wild birds closer to our home, I think at this time, my personal recommendation would be to take them down. And to do so, washing my hands and carefully, ideally with a mask on.
Thank you. Thank you again, both of you, both Dr. Leslie and Dr. Sander, for your presentations. Really appreciate that and helping answer some questions for the community. Just as to wrap up, we'll get back to this. The next Fast Facts sessions coming up in March is the Wisdom in Life, Wisdom in Health, Clinician's Guide to Elder Care Resources and End-of-Life Considerations. And then in April, Prenatal Care and Reproductive Health Care Primer, Health Primer for primary care physicians. And you will have the link to register in the follow-up information. This is a way you can reach out to us as well. You can use this QR code if you have questions. You're not sure about the things, things that you asked about today, those questions that pop up in between, ideas for future webinars, places where you think that there could be more information and ways that we can help the clinical community. Feel free to submit those here. We welcome them and appreciate your involvement. And, public health happens when astute clinicians put pieces together. And so when you're not sure how to report that or question, things that you want to share, this is an opportunity to do that, as well as with your local health department. And if you haven't, it's really important. This is always the message, sign up for Sirens. This is how we get out our public health messaging to the community. You know, we look for multiple opportunities, but this is our primary way. So please sign up for Sirens so you can get the guidance that we send out, health alerts, and so forth. And for those wishing to obtain CME credit, complete the evaluation survey and quiz at the end of this webinar utilizing the following web link or QR code. You can link here and that will be sent out to you. Afterwards, CME is only available for live attendance, and reach out to us if you have any questions. Thank you so much. Have a good day, everybody.
Thanks all.